Good morning, everyone. I see people are entering our education exhibit. Dr. Maria Bashir and I are hosting it, so I'll give it a few more minutes just so more people can log in. Okay, we have 58 participants. Marvelous. So I think we can get started because we have some cases that I would love for the medical students to take. So the ones that are x-rays, it's super easy because there's just the image to look at. I want you guys to unmute yourself to be comfortable. This is a fun discussion as much as we can have it when we're not live and on Zoom. There is on the top of your Zoom, there's a little function called remote control. If you go to the remote control, you can ask to take control so that for the CAT scan and for the MRI that I will have later, those of you who want to participate and actually live scroll, it's possible. You just have to ask for my control. And then all you have to do is when you request control, I'll allow it. And then you have to give it up once you're done taking the case. So don't be embarrassed. This is all supposed to be fun and educational. There's no bad ideas. You guys are medical students, not sitting at the radiology board, so wrong answers don't matter. We are here to all participate. So I have a portion of an x-ray up. So this is a patient who has a shunt, a ventriculoperitoneal shunt for hydrocephalus. And when they do these shunt series, they do different pictures where you can see the x-ray, you can see the shunt, how it's connected when it's going into the brain, the part of the lungs, the part of the abdomen, because we're supposed to see the entire length of the shunt. So the key image is here. Would anybody like to tell me what they see? Or tell the whole group? People are doing it into chat. I'm very sorry about my video. So this is my workstation, which is actually my real pack, so I can pull up interesting cases and have the whole case available for you with the follow-up. And I don't have videos on my computer screen, so that was a question asked in chat. So I apologize for that. You have to look at my picture when I talk. I'm sorry, but okay, who's up?
Hi, can you hear me?
Yes, John, who is this?
Yes.
Welcome.
So I see some radiolucency below the left hemidiaphragm. That's what stuck out to me immediately.
Oh, right here. Excellent. Yes. That is definitely lucent. I like the fact that you're using the right words for the right study. In X-ray, we use dense and lucent. This would be gas. So this is, it's a finding, but it's a normal finding. So this is gas within the stomach. This patient is standing up. So we know gas dependently, right? So when we're standing, gas rises over the fluid. If the patient was laying down, it would look a little different. So this is the stomach bubble, as it's called. Under the diaphragm, the stomach lives in the left. I think this might be obvious, so I don't want to offend you if it's obvious, but just so you remember, in medical school, you probably learn that in radiology, we flip everything. So your right is the patient's left. So this is the patient's right, this is the patient's left. And in the left side, under the diaphragm, lives the stomach. So good finding, but not the abnormality. So what do you think? What are some things that we can see on chest x-rays? When you round with the ICU or you round with the medicine service, you always look at x-rays and your residents and attendings discuss what are some things, some pathology that you think you can pick up on a chest x-ray?
Well, pleural effusion would certainly be something that I think I'd be able to pick out, or some sort of consolidation in a lung field. I know that.
Exactly. Okay, very good. So these are the pleural margins, and there is a little meniscus sign. So there is a little bit of fluid, but that's normal. All of us can have a little bit of fluid, and that's not necessarily pathologic. So as far as consolidation, what does that look like? You said, I think you used the word consolidation, right? Or pneumonia?
Yes. Yep.
Okay, what do you think that looks like on a chest x-ray? So normal, I guess you know what we can do, and I don't know if this is obvious for all of you. So you can see the bones, right? We all see the cardiothymic silhouette. That's a normal function, the cardiac silhouette, and all of the mediastinal contents that live here as an x-ray. You're taking a three-dimensional human being and putting him in 2 dimensions. So you have tissue overlap. And then you see bone, from the ribs. You see bone from the scapula and the clavicles. And then you see this little shunt, because that's all different densities. Air in the lungs, let me try to make it bigger for you. Oops, wrong thing. Should have the little pulmonary arteries. Is there something that you might be catching that doesn't? This is a super tough case. Anybody else care to take a guess? I'll tell you, look at the upper lungs.
Can I jump in?
Yes, hello,
hear me?
Brandon, please jump in.
Hi, Brandon, a fourth year medical student. I see something that may look like a small mass just below the right clavicle.
Excellent, you nailed it, good job. And then what we call, when we're teaching all of our residents, we call the satisfaction of search. When you find one thing, you're like, great, I got it, I'm done. There's actually a similar looking, although less dense mass here. So I'm trying to window level it. So you are right, and here is for your completion. So this was a patient who had a shunt series just to make sure that the hydrocephalus was draining correctly. This is a lung CT. Let me actually put it up on the coronal so you have the exact same visualization that you do with the x-ray. And I apologize because this is a live pack, so I have to pull them up really quickly. They're not preloaded. So here you go. So these little densities that you identified correctly on the right, this patient had lung cancer in both upper lobes, incidentally caught on a chest x-ray, performed for a completely different reason. So this is one of the benefits of being a radiologist. It's you get to solve puzzles and look at everything. You're not necessarily looking at it to answer a question you're being asked, but also looking for everything else and thinking of all the possibilities of all the diseases that can happen. And sometimes you save lives because you diagnose something the patient was unaware of. So excellent case. I have to unshare this screen very quickly so that I could pull up the next one. I do have a companion case just for interest. Okay. So this is another case, a patient who just had a chest x-ray. So as you can see, the same thing, the lungs are a little more radiolucent. Here is that little stomach bubble that we discussed. And again, this x-ray was being performed to evaluate the tubing. This is a triple lumen catheter put into the SVC. And if we look again, now this is a companion case, so it's going to be the same finding. Do you see that this density is not the same as this density in the upper lobes? So this is another lung cancer caught by a chest radiologist. And I can show you the CT real quick so you could see. Help with the measurement. So you can see that chest x-rays give you a lot of information. It's just a process to learn how to look at them and what to think about. Okay, so now we're going to go to a totally different type of pathology so more students can take turns.
I think chest x-rays are super difficult, by the way. I think it's like so much easier to look at cross-sectional imaging. So yeah, good job getting those cases, guys.
Yeah, that was excellent. That's a board style question for the trained radiologist to see, can you, okay, so I'll share the screen. And then we have a chat.
X-rays are actually much harder than cross-sectional. This is Karina Yang, one of the organizers. X-rays, they may seem simple. It's just, you know, one plane, but what you have on CTs and MRIs, everything is so much easier because you have multiple planes. And so X-rays are really tough. You can miss a lot on X-rays, which is why we have cross-sectional imaging. And same with head CTs. Head CTs, they sound simple to read, but we can actually miss a lot of things, which is why we have MRIs. So great job.
Yeah, that was absolutely excellent. So we have another case, totally unrelated. This is, whoever wants to actually try to play along, you can go to, if you click the remote control, I'll give you access and you can scroll through the study and we'll go through a very quick way to just how to look through this. This is a CT. Okay, welcome Ash, here you go. Go ahead and take it away. This is a young woman. She is having vague abdominal pain and fullness. Oh, and admits more. Hold on a sec. Let me just take control for a sec. Someone's asking to be admitted. Okay.
Oh, you don't need to do the admitting.
Oh,
part.
okay, I don't.
No, no, no. We'll-
Okay, sorry, Ash, go ahead. The mouse is yours. Is it working? Huh. Ash, are you able to, it says you're live. Are you able to scroll?
No, it wasn't letting me move the thing.
Okay, hold on. Request control one more time so I can give you, because where are you? Approve. Here you go. Okay, it should be all yours and you should be able to scroll. Still not letting you?
Ash, did you get a little message on your screen that says, do you want to take control, something like that for the mouse?
Yeah, I did.
And you
Okay.
clicked on it and it's not allowing you?
No.
Oh, I'm so sorry. We just practiced this and it was. All right, but you can still move the mouse. So do you want to point out the finding and try to go through it and we'll help you out?
Oh, can you guys see my mouse on your screen?
I see the mouse.
The other option is the arrow buttons on your computer. If you're not on an iPhone, if you're on a computer, you should be able to use arrows buttons and see if that will help. If not, then I think we just point at things.
Oh, there you go. Look at you. You're doing this annotation. I love it.
Is it toxic megacolon?
No, but good guess. So when you are coming up with these diagnoses, what are you looking for? What have you been taught, or how do you kind of think through this?
Well, I'm a first year medical student, so we
Oh,
have
you're a first year. Oh, welcome.
I see white, so that makes me think there's blood.
I see. Very good.
And the colon isn't supposed to be that. I'm guessing that's either large bowel or it looks very dilated. The bowel looks very
Okay.
dilated depending on if it's
Perfect. So
small
you have
or
a
large.
structure that looks dilated to you. Excellent. Do we have any maybe third or fourth years medical students who just have had a little more experience? So you didn't get the diagnosis, but your thought process is very good. You're looking at where you are in the body and you're guessing large colon because you are right. The large bowel does live. And I'll scroll through it later and to show you the entirety of the large bowel, but that is an area where the large bowel lives. And that is a good, it's excellent thinking to kind of think of what lives there and work off of that. So that you are right about, but not exactly the diagnosis. Is there an older student who might want to help Ash out?
More senior, not necessarily older.
That's right, more senior in training. So let me, I think, Ash, if you can stop share so I can give it to someone else, whoever wants to participate.
Hi, this is Nanditha. I'm a third year medical student.
Perfect, welcome.
I'm thinking in terms of pathology. So I'm thinking this might be a mass. So in order to differentiate what exactly it could be, maybe we can look at the different densities of the mass because I see different opacities throughout the dilated structure.
Okay, excellent. So that is excellent. And then we also have on chat a patient guessing the a student saying they think what the location is. So what you are both saying is absolutely perfect. So you have to look at, where we are and you're looking at the densities. So when you're saying you're looking at the densities, you're trying to figure out what this mass is. One of the primary things to do is figure out where is it coming from, right? So one thought from our more junior student was that we're at the bowel. So for you, if you look, you have to basically scroll back and forth to follow all the structures. So does everyone see this tubular structure that's continuous as I scroll, going all the way down to the rectum, and then I can scroll it back all the way around the patient's body? This is the large bowel. Okay, so here it is, and then it goes around, right? So our large bowel, if you remember from anatomy class, it just kind of goes in a nice rectangular way around the patient, starting at the terminal ileum, going up under the liver, across and down, and then into the rectum. So this structure is actually separate from the bowel. If you look, you could see the fat, and fat is under the skin. So fat density under the skin, you could see the fat density between the structure and the bowel. So this structure is actually not coming from the large bowel. And this, with the bright white that Ashley were talking about, this is oral contrast material within the small bowel loops. Okay, so this mass, you are correct, Nadithia, this mass is, it is a mass and it's sitting separately. Can you guess, in a young woman of reproductive age, in the left lower abdomen, where this mass could be arising from? And I'll scroll so you could see.
Yes, I'm thinking a left ovarian teratoma.
Excellent. So you're thinking left ovary. So teratoma is one option. And then this is where you look at the densities. So what densities are you seeing in this ovarian?
So I'm seeing like fluid levels as well as maybe some fat strandings.
Excellent. So the actual diagnosis is a dermoid. It's a dermoid cyst, which is the mature cystic ovarian teratoma. So you are right. You got the diagnosis. And the way we diagnose it for all the other students who are earlier in their training is we look for, remember, the teratoma is actually a structure that has, it's a neoplasm that has multiple germ cell layers, right? And then, so you do have fat, and the fat is very helpful. Sometimes you could see calcium from teeth. You could see fat fluid levels and calcifications. So that is excellent. This is a ovarian dermoid, or otherwise known as a mature cystic ovarian teratoma. Excellent.
I wanted to give a shout out to Arjun Biju and Yomar Crispin also for getting that right answer in the chat. So great job, guys.
Yes, I'm seeing the chat. Excellent. Okay, so let me unshare again for 1 second. Just because the patient names keep popping up, I can take them off, but not all at once. So I apologize for a little bit of this. Okay, and we have a neuro case near and dear to my and Dr. Yang's and Dr. Bashir's heart. Now we can all play along.
Olga, can you hit F6, please?
Yes. Okay, so did it share? Because I switched the screen. That's so weird.
Yes, it already shared,
Oh,
unfortunately.
Okay. So we have a 19-month-old child with swelling along the scalp above the right eye. So let me put up a coronal. So we have bone windows over here, and we have the soft tissue brain windows over here. And if we can try the scroll thing again if somebody would like to take the remote control, because it did work right before. Okay, Divya, here you go. See if it works. Is it working for you?
Hi, sorry. When I try remote control, I don't think I can't. Let me try just one more time.
Yeah, because it says it's waiting for you to share, and then it said you're taking it. Okay, so go ahead and ask for that control.
Sometimes there's glitches if the Zoom is not the most recent version. This is the area where things get glitchy. So in case your Zooms are not 100% updated as of literally this morning, sometimes those things don't work. So if it doesn't work, I think we can just move on.
Divya, it says you're doing it. That's not me.
Perfect. Okay, thank you. Thank you for having me participate. So first I'm just gonna scroll, and I see like on the right inferior aspect of the skull, it seems like on the bone window, the bone is not continuous. So I feel like there's maybe a broken bone, and then there's that swelling like you were mentioning, Dr. Pasternak-Wise, on that area. So I'm just scrolling through.
And if you double click on any of the 4 images, you get that image bigger. So it'll take up the whole screen if you just double click. That's.
Oh, okay. Then maybe I'll click on the left lower
There
one.
you go.
Yeah, okay. So I want to kind of start at the base of the head.
Okay, that's perfect.
Okay, I think I'm at the base. And so Now I'm just trying to get to the, like, where I think the eyes may be. Sorry, I might be struggling a little bit.
Oh, that's perfect. That's exactly what, this is the fun part. So there you are.
I'll give you a hint that things are not always inside the head that we look at on head CT. So think also beyond the confines of the skull.
And if you're not as used to axial imaging, that's why I pulled up the coronal so that you will be looking. If you just double click, it'll make it small again. And then you can look, double click on the upper left, and it'll be like you're looking at the patient, right? Like he's facing you and you're looking at him as you're scrolling through to see better detail of where this is.
Oh, okay. Thank you. So I feel like there's, like the swelling is kind of connected to the right, like globe.
Mm-hmm.
Right?
There's definitely, this process definitely does go into that orbit laterally. So it is entering the orbit. It is invading into the orbit. And
Okay. And I think it's also like a heterogeneous, like kind of swelling with like hyper and hypo densities. Apart from that, I don't know if I can describe it any further.
Okay, we are having a very active discussion on chat, but I don't want to steal my scroll. Maria, do you mind reading all the options?
Yeah, sure. So we have Ash saying orbital cellulitis that eroded through the bone, and then Brandon saying orbital rhabdo. Somebody else saying a bone tumor, question mark. Somebody else saying mucor. So those are all awesome pathologies.
And those are all possible, right?
Yeah, those are all something to think about. Yeah.
So, Divya, you have the screen. What? So you said you have different densities, and you have this mass. Somebody had said, you had said the bone is fractured, and that I can't scroll up to see who said it, but they said invading the bone. So what do you think it is? Do you think the bone is broken, or do you think it's being invaded by this mass?
I think it's being invaded by the mass.
Perfect. Perfect. It is. And so if you want to release control, I can show you because we only have a few more minutes. So I want to be able to pull up the MRI, which I can do that if I take the control.
Just release the control. Thank you.
Oh, there you go. Perfect. Okay, so we are right. So here's this mass. It is invading the calvarium and eroding it. The calvarium is gone here. It's also invading the lateral orbit. If you want to know if the bone is broken or invaded, you sometimes have to look at the margins. Usually if it's a fracture, it's just a fracture line. I'm sure all of you have probably seen fractures. You just have a clean line. Whereas if the bone looks a little frayed, if I can make you believe that it's a little frayed right here, that is where the bone isn't just being snapped, but it's being actually, a process that's destroying it. So these irregular margins. And so that is what this CT is giving us. You could see the bone, it's not perfect. It's a little thinner here. It's completely gone here. It's a little thin here. So we do have the calvarium being invaded, and then this portion of the orbital roof. So here we have the MRI. And this child also had an ultrasound just to see. So on ultrasound, you could see, on ultrasound, we call things echogenicity. So this is the skin, because remember when technologists or doctors do the ultrasound, when you put a probe to the skin, you see the skin and you see what's under it. So you have this mass. This is your calvarium that's being invaded. And there's all these little speckles within this mass, which could be little calcifications, because if you see it's the same echogenicity as the calvarium, this is what bone looks like on ultrasound, or it could be little fragments of bone. And then we do the MRI to really see the structures. Now let me show you a couple of the pertinent images. Get that coronal. So what we have, so this is the same mass you were seeing on the code alert. Code for this session is calcium score. Oh, okay. So what you see is this mass that you saw on CT. On MRI, this is a T1 and this is a T1 post contrast. So what we have done between this image and this image is inject intravenous contrast into the patient. And if you can believe it, right, the mass went from being kind of a lighter shade of gray to a very brighter shade of white. And so this means it's enhancing. So there's contrast enhancement within this mass and also contrast enhancement within that residual portion of the calvarium. And you could see here, just like Divya pointed out, that it is invading the orbit over here. And it's also invading the muscles of the face and invading into the space in the intracranial fossa, into the intracranial space. Dr. Yang, is there anything else we can give them as hints or anything else you would point out?
No, sorry, I'm jumping between things. So I'm
Oh,
not
okay, good. I
focused
thought
on
you
your
were.
session. Yeah, Maria's mainly on.
Maria, please step in. Is there anything else you want to give them as hints?
Well, like, I don't know. I don't know if they would really know like patterns of enhancement, at this stage,
true.
so yeah, it's a mass. It doesn't look like it doesn't look like an infection. I don't see any inflammatory pasturanic or anything. So we'd go down the pathway of a mass of some sort needing tissue.
Okay, excellent. And we have some wonderful guesses from people. So Brandon thought orbital rhabdomyosarcoma. So so this child is 19 months old and this mass was around for a couple of months. So the orbital cellulitis that you guessed, Ash, is a good idea. Orbital cellulitis does affect bone, but it didn't have the inflammation that we usually see, which you have just not seen yet. Rhabdomyosarcoma, bone tumor are thoughts. I'm just looking at our discussion. Mucormycosis is another thought. That's a fungal infection. Again, this doesn't really follow infection patterns, and we just don't have enough time to obviously go through that. Dr. Murthy, Gian, am I saying your name correctly? Your guess is LCH.
Yes,
So for
ma'am.
the
Although
younger-
I'm not a doctor, I'm just first-year medical student.
You're a student doctor. Can you please explain how a first-year medical student gets the slam dunk correct diagnosis?
Well, my father's a radiologist, and I think I've seen a case like this before a couple years ago when shadowing him. So,
I
um,
see.
yeah,
Okay.
that it was a total. I mean, it's not really. It was a guess on my part. I just know that in kids,
That's right.
Langerhans cells, just abnormal proliferation. I just that was what it was.
Absolutely true. So the people,
Excellent.
Nadithya, you guessed neuroblastoma, IJ retinoblastoma. Those are all absolutely wonderful guesses, and those are absolutely in the differential. So when we provide a differential diagnosis, we don't necessarily look at images and say, this is the diagnosis. LCH, the Langerhans cell histiocytosis, and all those tumors and mets are all possibilities in a toddler who has a soft tissue mass that's expanding and eroding the bone. This ended up being Langerhans cell histiocytosis, which for a little review is the most common location for Langerhans cell histiocytosis is the bony skeleton, and the skull is involved 50% of the time. The second most likely bone to be involved in the process is the pelvis and then the femur of the leg. So this is an inflammatory lesion, and like Gian told us, it is a process that is more common in youth, more common in boys. So this is a pediatric 19-month-old boy, pediatric population, and that is the diagnosis. But for all of you who went with some kind of a tumor that does also affect the pediatric population, such as neuroblastoma and Ewing sarcoma, which is a primary bone lesion, those are all excellent guesses. And I think, I'm not sure I knew this in medical school, so I think you're all absolutely amazing. And we only have 1 minute left. So does anybody have any questions? And I hope you all think about radiology, because in this half an hour, I'm very impressed with you.
Yes, we are actually out of time. They're going to close the room soon so we can move on to our next session. So hopefully you got the code that Dr. Bashir put in up above for the survey, post-survey entry for the grand raffle prize. And I'll let you guys head out of here and go back to the main site to click on your next session. This will be, all the links will be up on the site for the next session. And don't forget to do the post survey. It opened at 10 a.m. if you are leaving early. Thank you.